Hi guys, good evening, good evening, good evening. I'm Dr. Sandeep, your surgery guy. Welcome to the second episode of our BLS series. We are continuing on thyroid. Yesterday we started with the thyroid anatomy. Today we are going to pick it from there. So I hope all you guys are tuned in. So let's start the session. Uh, Again, as we have started our first session yesterday, whatever you feel like incorporating it or you want to suggest it, feel free to tell me on the comment box as well, so that we can continue to improve this series and let's make the series one of a kind. All right guys, I do have an access to the chat box. Okay. Hi, good evening, good evening, good evening. We have Osama, good evening. Kushu, good evening guys. तो राइट सो आज थोड़ा सेटअप भी हल्का सा चेंज कर दिया है. कल बहुत स्टैटिक मोड था, जस्ट टू टेल यू दैट हाउ डॉक्टर्स यूजुअली टीच अप्रोचिंग इन दैट वे, बट नाउ लेट बिकम अ बिट जेंजी तो थोड़ा बहुत सेटअप वगैरह भी चेंज करके ना और थोड़ा इंटरेक्टिवनेस लेके आते हैं. गुड इवनिंग मंसूर, गुड इवनिंग गाइस, गुड इवनिंग दुशांत. I get charged up looking you guys, ki when you come up in time and you're waiting and just that shows enthusiasm. All right, so without wasting any further more time, let's get started. Aaj ka day jo hoga, it will be more killing. We'll be talking about a bit more anatomy in the thyroid gland. At the same time, we'll touch upon the thyroid physiology, and then we'll talk about the goiter if time permits. So let's begin. So aaj ka topic. So yesterday we left at the basic anatomical orientation. I'm continuing from there in the anatomical section only. So we have a triangle that I wanted to discuss. A lot of triangles in surgery. Surgeries and triangle. It's a beautiful love story that you have. It's a story between you, your skill, and your patient. Okay? So everywhere you get triangles, triangles are full in everywhere in surgery, and every triangle has an essence. So we'll be talking about such triangle in a thyroid gland, which is what we call it as the Bayer's triangle. Have you heard about Bayer's triangle? Now, Bayer's triangle is important as a surgeon for me because I want to locate one of the most important nerves that are going to pass through the thyroid gland. Yesterday we have discussed it, and that nerve is your recurrent laryngeal nerve. As a surgeon, I would never want to damage the recurrent laryngeal nerve. In fact, there's a very beautiful question that was asked by my HOD when I was in my residency. He said, Sandeep, tell me, what is the goal of the thyroid surgery? And I said, to remove the thyroid gland, sir. No, he was like, okay. What you're telling me is the end result. Okay, you're telling the result of thyroid surgery is to get the gland out. What is the goal? You have to go with a goal. Then I said, sir, I don't know. I thought goal is to remove the gland. And he said, yes, it is the outcome of the surgery is to remove the gland. The goal is to preserve a recurrent laryngeal nerve. If you don't preserve the recurrent laryngeal nerve, you're no good as surgeon. So the skill depends upon identifying this recurrent laryngeal nerve and make sure that you do not damage it. So as a surgeon, I need to know all these territories where you can find this recurrent laryngeal nerve. So in this context, I'll give you a small orientation so that we can get a little bit more oriented towards it. I'll give a lateral view. Now on a lateral view, you take this as the representation of the trachea. I'm giving a lateral view of the trachea. These are our tracheal rings which are present, and I told you on the anterior surface of the trachea we have the thyroid gland. So without any doubt, I'm going to depict this is the thyroid gland. Behind this you have this guy. This is our guy which we're going to talk about in detail about it. Now this is a very peculiar guy, we would call it. This is the esophagus that you have. In between the trachea and the esophagus, you have a tracheo-esophageal groove. Now this groove that is present, the space that is present between the trachea and the esophagus, this is what we call it as tracheo-esophageal groove. So I'm giving you a lateral view from here. So it is going to be the lateral view. You have the tracheo-esophageal groove that is present. Now, let's imagine in terms of the vasculature that we're going to talk about. We're talking about the vessel that is going to come across. I'll talk about the left side only. So you can get oriented, right side, so to get oriented quite well. So this is the subclavian artery on the component side. So this is on the lateral view. Then you see this is the common carotid. The common carotid is going to take its path like this, right? So you have the common carotid which is ascending into the neck. This is your subclavian artery. Let's say if they're coming from the same trunk, I would say this is the brachiocephalic artery. This is your subclavian artery. We all know that the carotid artery will further go and bifurcate it. I'm not worried about it. I'm talking about the common carotid. We have the subclavian artery, and yesterday we remembered that I told you there's a thyrocervical trunk which is going to arise from here. Through the thyrocervical trunk, you have these blood vessels which are going to supply to various components, and from here, from the thyrocervical trunk of the subclavian artery, you will notice that the inferior thyroid artery is going to arise. It is going to go behind the common carotid, and once it goes behind the common carotid, it is now going to supply to the thyroid gland, and the multiple branches are going to be given across here. This is your inferior thyroid artery from a lateral view. Now if you highlight this vessel, this is the inferior thyroid artery which is arising from the thyrocervical trunk and supplying to the thyroid gland. Now you see there's a small triangle that is being formed between these structures. What is this triangle? Between the inferior thyroid artery, the tracheo-esophageal groove, and the common carotid. If I highlight this triangle, you have to be precise. You see, this is the triangle that we're talking about. This is the triangle that you're talking about. In that you have the tracheo-esophageal groove. This is the common carotid that you have. You have the common carotid, you have the inferior thyroid artery, and then you have the tracheo-esophageal groove that is running across here. Now why it is important is we have a nerve, that is your recurrent laryngeal nerve, is going to pass through this segment. So this is where you will identify the recurrent laryngeal nerve course. So this is where you will identify the recurrent laryngeal nerve course. So this triangular area, I'll just label it down for you so that you can understand better. This happens to be the inferior thyroid artery. This happens to be the common carotid, which you can see. This happens to be the common carotid. So we have the common carotid, we have the inferior thyroid artery, and then you have this area which is your tracheo-esophageal groove. Your tracheo-esophageal groove, and through this tracheo-esophageal groove, you have this guy who is running, and this guy who is running here is our recurrent laryngeal nerve. So this is your recurrent laryngeal nerve. So you should be extremely careful when you're dissecting. You should be extremely careful when you're dissecting your area of the Bayes triangle, because there you are going to get your recurrent laryngeal nerve. So you have the thyroid gland. We're talking about the lateral view. You're standing here. I'm giving you this view that is on the lateral view. On the lateral side, this is thyroid, this is the trachea, this is the esophagus. You see, this is the subclavian artery. I will label it down for you. This is the subclavian artery. This happens to be the common carotid. Then you have the thyrocervical trunk, which is coming out from here. The thyrocervical trunk gives rise to inferior thyroid artery, which is going here. And in between this, a small triangular component is what we call it as Bayes triangle. Now you need to be extremely careful when you're dissecting this triangle. You do not want to injure the recurrent laryngeal nerve. Is that clear? आई बात समझ में सबको? Is everybody oriented to this? कि भाई ये Bayes triangle है क्या? Sorted? Right? So this is how the Bayes triangle is going to unfold. We will remember this so that we don't make any mistakes. Now, in order to prevent such more mistakes, we have our good friends which are called as the Cernia and colleagues. So they came up with a classification. So what is the Cernia? What is the Cernia and the colleagues classification? Now, Bayes came up with the idea that we should preserve or we should prevent the injury in the recurrent laryngeal nerve. Cernia and colleagues, they came up with the idea that we will try to prevent the injury to the external branch of the superior laryngeal nerve. We said, Cernia, how would we preserve it, or how can we prevent from making any mistakes? Cernia said, I will give you different classifications. The type 1 variety according to the Cernias and colleagues. Cernia and colleagues said, okay, I know that you know the thyroid gland. So let's say this is the isthmus of the thyroid gland. This happens to be the superior pole and the inferior pole, and these are the lobes which I've drawn. Now we said that obviously, you know, there is an artery that is going to come from here. That is going to be a superior thyroid artery, which is going to come and supply. And there is this vein that is going to drain from here. That is going to be the superior thyroid vein. So this is the neurovascular complex that is there. Cernia and colleagues said that the superior laryngeal nerve, when it comes, it usually crosses it usually crosses the neurovascular bundle and then it goes behind. Now, if the distance between the pole and this crossing, if it is more than or equal to 1 centimeters, it is what we call it as the type 1 variety. It is what we call it as a type 1 variety, right? Then we have type 2A variety. So according to type 2A, the proximity of the superior laryngeal nerve, that is the external branch of the superior laryngeal nerve, is going to decrease. I said what is going to happen. So it says, okay, fine, take this as a representation of the thyroid lobe that we have. We will adjust a bit, we'll go down. Okay. So in 2A variety, it is the same component you have. The neurovascular bundle, that is superior thyroid artery, is going to come. The inferior thyroid artery also going to come. Now this time you will notice that the superior laryngeal nerve just crosses above the pole, right? So we normally say, or rather than say, we will say that it's just crossing above the pole. That indicates that the distance between this crossing and the superior pole is less than 1 centimeter. The distance between the superior pole and the crossing is less than 1 centimeter. It is 2A variety. It is going to be 2A variety. Then we have the type 2B variety. It's a type 2B variety. Now in a type 2B variety, what is the probability that you have? Again, this is the isthmus here. This happens to be the lobe. This is the lobe of the thyroid gland, and this is the another lobe of the thyroid gland. Now you see that here again you have the superior thyroid artery, then you have the superior thyroid vein, and this time you see that the superior laryngeal nerve does not cross the neurovascular bundle, it crosses the lobe and then it goes across here. So if it crosses below the thyroid pole, if the crossing of external branch of the superior laryngeal nerve is below the thyroid pole, it is going to be your 2B variety. So according to the Sonia and colleagues, they said in order to prevent injuries in the superior laryngeal nerve during the surgery, you should know that where exactly the superior laryngeal nerve is flowing out from. So this structure that we have drawn, this is your superior laryngeal nerve. So this is your superior laryngeal nerve. This is your superior laryngeal nerve, right? Now, we asked Sonia and colleague that how do we prevent this injury from happening. Sonia and colleague said, look at the superior laryngeal nerve. We have to see where is it crossing. If the distance between the superior pole and the crossing is more than 1 centimeters, it is type 1 variety. If it is just at the pole or within 1 centimeter of the superior pole, it is type 2A variety. If it is going below the pole, that means it is not on the level of pole. It is below the level of pole. It is 2B variety. As a surgeon, why should I know this? Because during the surgery, I should be able to trace the course of this nerve. But more importantly, I also know that when I'm dissecting the artery and the vein of the thyroid gland, we have to ligate the superior thyroid artery as well as the superior thyroid vein. Now the concept is, as a surgeon, we'll always tell you that, or as a trainee when you come to me, I'll always tell you that you have to ligate the artery and vein close to the gland. Always close to the gland. Why? Because if you're ligating far away from the gland, you don't have that plane and you don't know the exact proximity. ऐसी हवा में नहीं बांध सकते हो ना, तो कुछ ना कुछ होना चाहिए base. You should know somewhere that you can rely on to tie a vessel, and usually it is always closer to the organ or always closer to a gland. Now, I will always tell you that whenever you're tying the artery or the vein or ligating the artery and the vein, always ligate close to that of the thyroid lobe or the thyroid gland. Now, my question to you is, if I have taught you as a surgical trainee that you have to ligate the thyroid vein and thyroid artery close to the gland, in which variety of Sonia and colleague do you expect the maximum possibility of injury to the superior laryngeal nerve during surgery? A quick feedback. So Sonia and colleague gave us 3 varieties, now type 1, type 2, type 2A, 2B, right? And I know that I've taught you that whenever you're ligating the vessel, it should always be closer to the gland. Now, because as you're going to ligate closer to the gland, which variety is going to be most likely to be hampered? Absolutely correct, guys. Now you're building the concepts with me and I'm super happy about it. That is why we say that type 2A variety is the one which is most commonly associated. It is the most commonly associated with injury during thyroid surgery. During the thyroid surgery. Bang on. So I'm super happy that you got this correct. Okay? Great, guys. So this is about the Sonia's and colleagues classification with respect to the orientation of your superior laryngeal nerve. Right? Now, let's move on to a bit of thyroid physiology, which we would have discussed it yesterday, but I'm taking it today. Right? Now we're talking about the thyroid physiology. So I'll not go into as much depth as our Vivek sir goes. I can't even attempt that. I will try to stick what is relevant from a surgeon's point of view. Okay? Now, from the thyroid physiology, what you need to understand is how is the iodine is being absorbed, is it taken by the thyroid follicular cells, how is the hormone synthesized, and how does it act in general. Now, you need to understand, like, let's take this as a representation. Let's say this is a follicular lumen. And let's say these are the follicular cells. Yesterday we have discussed the active follicular cells are those follicular cells which are going to be lined by cuboidal epithelium, right? On the surface of this cuboidal epithelium, you have these ion-gated channels, and these ion-gated channels are what we call it as the sodium iodine symporter, right? This is what we call it as the sodium iodine symporter. So the basic job is whenever the iodine is being brought, whenever the iodine is being brought to the thyroid follicle, it has to be absorbed into the lumen or into the follicular cell for synthesizing, right? For in order to synthesize T3 and T4. So sodium iodine symporter, sodium iodine symporter. It is the sodium iodine symporter that is going to bring the iodine into the follicular cell. So let's say you have taken up the iodine. In that context, I can also ask you what is the daily iodine requirement. Now the daily iodine requirement, to keep the patient euthyroid is going to be 0.1 to 0.15 milligrams per day. Right, this is the minimum amount of iodine that has to be consumed for a patient to remain euthyroid. Now, this iodine which is consumed is now going to go into the thyroid follicular cell. Now, when it goes into the follicular cell, what is going to happen? Now, to be very honest, the ionic iodine is useless for the body. Body says I cannot use it because it's stable. I don't want stable. I need people to be unstable so that I can react well. So this ionic iodine is immediately converted. This ionic iodine is immediately converted into free radical iodine with the help of an enzyme which is called as thyroperoxidase. We call it as TPO, that is called as thyroperoxidase. Now this iodine that is being released, that is a free radical iodine, will combine with tyrosine, which is readily available inside the thyroid follicle cell, and this will result in an organic compound. This will result into development of an organic compound. Again, this is also catalyzed by the enzyme that is thyroperoxidase. Now, this organic compound which is formed, it is going to exist in two forms, like as a dimer. No? One is going to be the monoiodo form. Another one is diiodo form. Monoiodo basically means it's a single iodine. Diiodo, there are two iodine components or two iodine molecules which are present, right? So it exists in the monoiodo and the diiodo form. Now, once this has happened, now we'll take up the patient, or this, sorry, I'm not taking the patient. The cells will take up the iodine and they will undergo something called as the coupling reaction. Now, this coupling reaction is also going to occur within the follicular cell. So, what is this coupling reaction? Coupling का मतलब ये है कि couple कर रहे हैं, ठीक है? तो couple का मतलब जुड़ना. So, क्या कर रहे हो? You are going to combine the monoiodo will combine with diiodo. So, 1 plus 2 is equal to how much? Please do not give me wrong answers. Being a doctor does not make you a bad math student. I know we all took medicine because we don't like maths, but we will challenge at every given step. So 2 plus 1 is how much? It is 4. No. Okay, fine. It is 3. I know. It is T3. So monoido combines with the diido form, that is to give our T3 component. Then the diido, that is 2 iodine molecules, combines with another diido, that is 2 plus 2 is how much? 5. It is 4, right? So it is going to develop into T4. So you have the T3 and the T4 that is going to be developed in this particular fashion. Again, this is catalyzed by the enzyme that is thyroperoxidase. So every single reaction that is going to take place inside the follicular cell is going to be your the TPO is the basic, the guy who controls everything. So TPO is the one which is going to take across the basic function on this. Now we all know that T3 is going to be the active form and T4 is going to be the passive form. Rather than saying a passive form, I would like to say it is called as a reserve form. So this is how the T3, T4 is going to be developed. Now when you look at this, let's say this is the follicular cell that is present. I'm giving you an ultra look of the follicular cell. Now in this you will notice that there are a lot of protein molecules which are freely floating. Now these protein molecules are actually the one which are going to bind to the thyroid hormones that have been secreted. So whatever T3, T4 that you've secreted, no, all this T3, T4 is going to be bound to these protein molecules. So hence they are called as thyroid bound. They are called as thyroid bound proteins, right? All these proteins are going to be bound. You will see few of these are going to be freely available. Very few of them will be available as in a free form, right? So you will notice when you look at in the thyroid follicular cell, you will see that 99% of these hormones, 99% of the T3 and T4 that is synthesized, it is going to be in a bound state. Bound का मतलब क्या है? जुड़े हुए हैं. They are going to be in a bound state. Now in a bound state, because it is in a bound state, you need to know to what it is binding to. अगर bind भी हो रहे हैं तो पता तो रखना पड़ेगा ना भाई किससे bind कर रहे हैं. इतनी नजर तो रखोगे, ठीक है? तो किससे bind कर रहे हैं? So remember, it binds with 3 important proteins. Mnemonic to remember them as gap. ये bind इसीलिए कर रहे हैं कि इनके बीच में gap ना रह पाए, ठीक है? Nobody wants to have any gap. They are binding because of that. And G stands for globulin. It's a protein. A stands for albumin and P stands for prealbumin, right? It binds to globulin, albumin and prealbumin, and remember the majority of it, the most of the thyroid hormone binds to globulin, and that is why हम इसको प्यार से बुलाते हैं कि T thyroid bound globulin. It's called as TBG or simply abbreviated as TG. That is thyroid bound globulin. Thyroid से बंधा हुआ globulin. It is called as the thyroid bound globulin. This is what we call it as the thyroid bound globulin, which is the basis of TBG. That is a thyroid bound globulin. Right? Now, this is how the hormone is synthesized, which is present across it. It is a bound state. And then you see this hormone, which is in a different shade. This is what we call it as the free form. Only 1% of the thyroid hormone is in the free form. And remember, the bound form of the hormone cannot be utilized by the body. It is the free form that is utilized. तो क्या ही फर्क पड़ा कि बना लिया इतना ज्यादा हार्मोन जब काम सिर्फ 1% का आया, ठीक है? So it is also like life only, no matter how hard you try, it is that 1%, that last 1% of effort is what is required to fulfill your dream. So the greatest saying is, the failure is always to those who quit at that 99%. That extra 1% is what it makes it 100. तो हम नहीं छोड़ेंगे, हम 100 लेके रहेंगे. So this one free form is what is going to be utilized by the body. It is utilized by the body. 99% it cannot be utilized because वो already committed है. 99% already committed है तो body के काम नहीं आएंगे. वही काम आएगा जो free मिलेगा हमको, ठीक है? So in that context, remember it is the 1% of the hormone that is going to be in a free state. Now, whenever the demand for the hormone requires, जैसे for example there's some increase in demand for the thyroid hormone, that is T3 hormone, body does not have the time to resynthesize the whole cycle and then give it back to you. So body says मेरे पास एक cheat code है. What is the cheat code? The cheat code is whenever there is increase in demand, whenever there is increase in demand of the thyroid hormone, How do you compensate? Rather than going back to the thyroid follicle and tell the follicle thoda hormone dena, isse acha kya hai? You should have a backup, and the backup is always convert the T4 into T3 whenever the demand increases. And this instantaneous conversion is what we call it as the peripheral conversion. This is what we call it as the peripheral conversion, and the peripheral conversion is done with the help of the enzyme which is called as 5'-deiodinase. This is what we call it as the 5'-deiodinase, right? So this 5'-deiodinase converts the T4 into T3. जब भी जरूरत पड़ेगी T4 बोलता है मैं हूं ना, ठीक है? And that is why remember the ratio of T3 T4, the T3 will always be less when compared to T4. So the ratio of T4 will be quite high. Precisely talking, it is around 16:1, but you will always notice that T4 will be produced in a greater form when compared to T3. क्योंकि T3 whenever see body is utilizing T3, no, तो T4 बोलता है तू जा खेल ले, जब तेरा दम खत्म हो जाएगा ना तब आके मैं तुझे बचाऊंगा, right? So it's like the T4 is your backup. It says don't worry about it, go fight, and whenever you feel less, call me, I'll come and convert for you from T4 into T3, and this is your peripheral conversion. So this is how the thyroid hormone is going to be developed. It started from a very basic concept that how the iodine went into the thyroid follicular cell. From there it took its journey and eventually it is formed that T3 T4, right? It is your T3 T4. MSDN7 caption क्यों नहीं है सर? कौन सा caption क्यों नहीं है? क्या caption बोल रहे हो? I don't know guys, पता नहीं क्या caption, ठीक है? So this is how the T3 T4 is produced. अब T3 T4 बन तो गया है, अब release कैसे करेगा? Let's look at this. So we talk about who controls the T3 T4. So we'll start with the high command, and the high command for the entire phenomena is our big guy, and the big guy is our hypothalamus. So the big guy that is present here, this is the hypothalamus, right? This is the hypothalamus, and this hypothalamus is going to control our small guy. The small guy is your pituitary gland present in the sella turcica. Now this pituitary gland is going to control what we now call as the powerhouse is going to be your thyroid gland. The powerhouse is going to be your thyroid gland. So this is the thyroid gland that is present, right? So what happens is the hypothalamus says, I am going to produce a hormone. We said, what are you going to produce? The hypothalamus says, I will produce an hormone which is called as the thyrotropin regulating hormone. We said, what does TRH do? TRH says that I am going to go and stimulate the pituitary gland. And once it stimulates the pituitary gland produces a hormone which is called as TSH, that is your thyroid stimulating hormone. So hypothalamus gets stimulated, produces the thyrotropin regulating hormone. It goes and stimulates the pituitary gland. The pituitary gland, absolutely correct, the anterior pituitary gland, which is going to produce your thyroid stimulating hormone. Now what is the function of the thyroid stimulating hormone? The thyroid stimulating hormone has two functions. Number one, obviously the name itself is saying thyroid stimulating hormone. It will go and stimulate. So it stimulates thyroid follicle. It is going to stimulate the thyroid follicle. On the other hand, whenever the TSH is in excess, it will also act as growth factor. It promotes the hypertrophy and hyperplasia of a cell, right? So you need to understand that TSH has two basic functions. The major function, of course, is to stimulate the thyroid follicle cells, but whenever it is in excess, it can also stimulate the thyroid follicles to undergo hyperplasia, and this forms the basis of your goiter. आगे चल के फिर बात करेंगे, ठीक है? TSH का काम क्या है? What is the TSH going to do? The TSH says goes into the thyroid follicles. The TSH goes into the thyroid gland, stimulates the thyroid gland. Once the thyroid gland is stimulated, it is now going to produce the hormone that is desired, that is going to be T3 and T4. Now whenever the T3 T4 concentration has become more, or whenever the T3 T4 concept or the concentration remains to an adequate level, now this is now going to go and tell the hypothalamus that hypothalamus, we have enough amount of the T3 T4, kindly stop working, and this is what we call it as the negative feedback. This is what we call it as the negative feedback. Now, negative feedback does not mean a bad feedback. Negative feedback is an opposite feedback. So, negative feedback क्या बोलता है कि whenever the concentration of T3, T4 is going to increase, with the help of negative feedback, it is going to cut off this drive of TRH. So, the TRH will decrease, the TSH will decrease, the thyroid follicles will decrease. If the follicular stimulus will decrease, the thyroid hormone release will decrease. Okay? So this is how the whole axis is going to basically work. So when I say negative feedback, no, don't see negative feedback as negative. See it as a seesaw, right? So what do you mean by a seesaw is, let's say, to understand this mechanism of seesaw, I'll just highlight it here. So when I say a seesaw, imagine that this is the pivoting point of a seesaw. Initially, this is how the seesaw leg is. On one side, I'm saying that there is thyrotropin, or I can say hypothalamus. On the other hand, we are saying the thyroid hormone, right? So whenever the weight of the thyroid hormone is going to increase, right? So that means when the concentration of the thyroid hormone will increase, agar weight increase karega, so this is going to go in this fashion. Okay? So rather than saying, we'll not say decrease or increase, we say whenever the concentration of the thyroid hormone is going to increase. Whenever the concentration of the thyroid hormone is going to increase, basically what is going to happen, it is going to go up, right? If the concentration increases, what is going to happen? Because of this seesaw mechanism, you will notice that this is going to pivot like this, right? Because of the seesaw mechanism, you will see that this is going to pivot in this manner. So you see the hypothalamus has gone down because the thyroid hormone has gone up. Okay? In the same way, let's say, if the hypothalamus, if the thyroid hormone decreases, let's say with the same seesaw effect, we say if the thyroid hormone concentration decreases, if the thyroid hormone concentration decreases, this is the thyroid hormone, this is the hypothalamus. If the thyroid hormone concentration decreases, the hypothalamus concentration will increase. Same here. Here, if the thyroid hormone concentration increases, the hypothalamus concentration will decrease. So this is what we call it as a negative feedback. So जब भी T3 T4 concentration बढ़ेगा, the hypothalamus will suppress. Whenever the T3 T4 drops, the hypothalamus is going to increase. Now my question to you is, if you have now understood that the negative feedback is driven by the T3's T4's concentration, if I ask you which is a major determinantal factor for a negative feedback, is it the T3 or is it the T4? Who determines the negative feedback on a major context? Is it a T3 or is it a T4? Quick feedback. Is it going to be T3 or T4? Okay, so we have an answer which says T3, but it is absolutely a wrong answer. The right answer is going to be, yes, Osama, you are correct. Snehajit, you are wrong. It is not T3, it is T4. Now imagine it this way. Okay, get this. जो लोग सोच रहे हैं कि negative feedback T3 determine करेगा. So let's say body has secreted T3 and T4. So T3 is less, T4 is more, right? T3 is less, T4 is more. Whenever the body requires the thyroid hormone, the T3 is being utilized, the concentration of T3 continues to go down. Now, as the concentration of T3 continues to go down, but body still needs more amount of T3. Now, if the negative feedback was controlled by T3, the minute the T3 will start dropping, what will happen? The thyrotropin regulating hormone will secrete, the TSH will secrete, then the thyroid follicles will release T3, T4, and what is going to happen? The T3 is going to increase, but T4 will further increase. Same way, again T3 decreases, again there's a negative feedback, T3 will increase, T4 will further increase. तो T4 का क्या काम है? वो तो बढ़े ही जा रहा है. ऊपर से एक और प्रॉब्लम क्या है कि जब भी जरूरत पड़ेगी तभी अगर आप बॉडी को बोलोगे T3 बनाने के लिए, तब तक आपका जो ऑर्गन है वो तो वेट नहीं करेगा. Whichever organ requires T3 at that instance of time, you cannot say no, wait, एक सेकंड मेरे पास अभी खत्म हो गया, मैं बोलता हूँ हाइपोथैलेमस को बनाने के लिए, वो बना के लेके देगा मेरे को, तब तक तू वेट कर. बॉडी बोलेगी चल चल इतना काम नहीं है मेरे पास, ठीक है. So in order to get balance into all this, whenever the T3 concentration decreases and if the demand is still high, what is going to happen? The T4 starts converting into T3. T4 ये T4 T3 में convert होता रहेगा, तो T4 का concentration start dropping, T3 picks up, but when this T4 concentration starts dropping, this is when the body realizes the reserve is dropping, and that drop in reserve tells the body, अरे यार अपना गोदाम खाली हो रहा, भरो, ठीक है. And because of that negative feedback, it will start making this TRH which goes into TSH, stimulates the follicles and develop T3, T4. तो आई बात समझ में कि negative feedback is majorly determined by T4's concentration. Very, very important concept. सही है? So we say the negative feedback is controlled by T4 concentration. It is controlled by the T4's concentration. Sorted? Clear? So I hope I made myself absolutely clear about the concept of the T3, T4's production and how the whole cycle is going to get controlled. Now comes your crude data. I know it will be a bit bothering, लेकिन बताना पड़ेगा, आपको सुनना पड़ेगा. So what is the normal concentration of TSH in the body? It is going to be between 0.5 to 5 micromoles per liter. 0.5 to 5 micro units per milliliter. Then what is the normal level of T3? T3 is going to be between 1.5 to 3.5 nanomoles per liter. Then you have the T4's concentration. The T4's concentration, it is going to be anywhere between 55 to 150 nanomoles per liter. You can see T4 is quite high when compared to T3, right? It is quite high when compared to T3, right? So TSH, T3 as well as T4. Now what is the half-life of T3? What is the T-half of T3? Now T3 is going to be finished in 24 hours. What is the half-life, that is T-half of T4? So to remember this, 4 plus 3 is going to be 7 days. So that is why it is reserved. No, ये body में आराम से घूमता रहता है. ठीक है? It can go on for the next 7 days. So the half-life of T3 is going to be 24 hours, but the half-life of T4 is going to be as high as 7 days. It is going to be as high as 7 days. ठीक है? So this is the basic objective behind the concentration and the thyroid physiology that you should be aware of. Clear? Now, before we move down, we'll talk about one basic concept of the whole, thyroid swellings per se, and then we'll start our journey. Now, there's something called as, whenever a patient comes to you with a thyroid swelling, I just want to touch upon this topic and then we will continue as we are supposed to do so. Now, whenever a patient comes to you with a thyroid swelling, especially if it is non-toxic, that means if it is not a hyperthyroid induced swelling. So you will talk about in detail, don't worry about it. For now, you remember you have to do something called as FNAC. Now FNAC stands for fine needle aspiration cytology. Fine needle aspiration cytology, right? So whenever a patient comes, we will do an FNAC, and that FNAC is what we call it as the fine needle aspiration cytology. It's a fine needle aspiration cytology. Now, in order to get the best result of what you're doing it, right, we have a criteria which is called as the optimum cytology criteria. This is what we call it as the optimum cytology criteria. Now, what is an optimum cytology? That means in order to get the best result from a swelling, you should take the sample quite well. Now, in order to take the sample, now how do you do an FNAC? I'll give you a quick component on FNAC. Let's say there is the thyroid gland which is present here, and there is a swelling in the thyroid gland, right? Imagine that there is a swelling in the thyroid gland that is present, right? And I want to know whether this swelling is malignant or non-malignant. Is it cancerous or non-cancerous? Is it benign or non-benign? Or is it inflammatory? So based upon that, I want to know what type of cells it is. So what I'll do is, I will take a 10 cc syringe. I will take a 10 cc syringe. It's an empty syringe, right? I will take the needle. I will prick the needle into the swelling pus. I'll palpate the needle, I'll prick directly into it, and then I'll suddenly pull it. This is called as fine needle aspiration. You're aspirating it. You will draw this with force. Now when you draw this with force, you will get some amount of tissue that is going to be coming into this needle, and that tissue you will spray it on a glass slide, give it to your pathologist and tell them to report and tell me what is it. So in order to get the best results, the optimum cytology criteria states that there should be a minimum of 2 aspirations. Minimum 2 times aspiration should be done. Minimum 2 times aspiration is to be done. Okay? On the other hand, before you start aspirating also, what is the size of the needle? So for an optimum cytology, the size of the needle, so that you get the best result and cause less amount of pain, is going to be a 23 gauge needle. It is going to be a 23 gauge needle. So minimum you require 2 aspirates, and in each aspirate there should be a minimum of 6 follicles per aspirate. There should be a minimum of 6 follicles per aspirator, and when you look at the follicles, there should be a minimum of 10 to 15 cells per aspirate. There should be a minimum of 10 to 15 cells per aspirate. No, we do 2 aspirations so that you get good amount of tissue. Right? In a single aspiration, you might not get an adequate amount of tissue. To get an adequate amount of tissue, I will aspirate a minimum of 2 times so that it's on the safer side. Rather than calling the patient again and then say, okay, fine, I'll aspirate again. It is better to aspirate at the same time. In a single go, twice aspirator, you will get a better yield and a better result. Okay? So this is in terms of optimum cytology. So in order to be a good pathologist, you should be in this context. Okay? If you get all this correct, then you will have a good notion of diagnosis. You'll be able to get, because you have good amount of tissue, the assessment is good, the reporting is good, you support surgeons well, because on that basis, what your pathologist is going to tell you, whether it is benign or malignant, my decision making is going to be further coursing from there. Okay? So this is the basis of, in general, that you want to know about the thyroid physiology as well. Right, so far any questions, quick feedback, guys? Koi sawal, koi shak? Anything that you wanted to ask? Beta, if you are in final year, no, and you're reading surgery, I would recommend you to read from Bailey only. Okay? Gray's Anatomy is something that is to be considered when you're reading in your first year. Okay? Once you've gone past your first year, you do not have the leverage of time and the energy to go back and read the entire Gray's Anatomy. Yes, sometimes some important topics, if you want, you're not very clear about the anatomy, you're not able to understand, you can refer back to Gray's. Okay? But then stick to Bailey as a final year student. If you're in first year, I would highly recommend you to read your Gray's Anatomy, which is, yes, I know it's an overstretch initially, but थोड़ा effort लगेगा. जैसे हम कर रहे हैं Bailey में on a daily basis, थोड़ा करके तो कर लोगे, right? What we put inference based on the cytology. So difference between the biopsy and FNAC. But biopsy में you take the entire chunk of the tissue. In a fine needle aspiration cytology, you aspirate the tissue. So it is not the entire chunk that you get, you only get an aspirate of a tissue. Okay? So the whole tissue, when you take it, is called as biopsy. If you're only taking an aspirate of a tissue, is what we call it as an aspiration. Okay? So what we put inference, we are coming to it, right? Based upon whatever the cytology that we get, your pathologist is going to give you a classification. Your pathologists are good at classification, so they have made up or they come up with a classification which is called as the Thai classification. It is what we call it as the Thai classification. Now, what is this Thai classification? According to this, they would report in the following fashion. They will say, we have a Thai 1 category. Now, Thai 1 category, you did not take the cytology properly, so it is non-diagnostic. So probably, as somebody was saying, sir, मैं 2 aspirate क्यों लूँ, मैं 1 ही लूँगा, तो 1 ही लेगा तो ले ले, आई नहीं diagnosis. फिर बोला patient को, patient बोलेगा एक बार तो क्या, तो बार-बार क्यों कर रहे हो, ठीक है? So in order to avoid that, take 2. Clear? On the other hand, You have Thigh 2 category. Now, Thigh 2, before Thigh 2, we have Thigh 1C also. Whereas Thigh 1 is non-diagnostic. Thigh 1C. We have Thigh 1C category. The Thigh 1C is non-diagnostic cystic aspirate. It is a non-diagnostic. This time the spelling was cystic swelling, so it is a cystic aspirate. It is a non-diagnostic. It is a non-diagnostic cystic aspirate. That is your Thigh 1C category. Next comes is your Thigh 2 category. Now Thigh 2 category is non-neoplastic. It is non-neoplastic. Neither it is benign nor it is malignant. There is no growth. Yes, it could be an inflammatory thyroid swelling or a goiter swelling. That will belong to a Thigh 2 category. That will belong to a Thigh 2 category. Right? Then you have a Thigh 3 category. Thigh 3, they will tell you that it is follicular origin. They'll simply comment that it is follicular origin. Remember, FNAC do not have the ability to differentiate between the benign follicular adenoma and a malignant follicular carcinoma. Whenever they have a gray zone or doubt, they would simply go ahead and tell that it is going to be follicular originated cell. Right? So we have the Thigh 1 category, which says non-diagnostic aspirate. Thigh 1C, which says non-diagnostic cystic aspirate. Then you have the Thigh 2 category, which says it is a non-neoplastic swelling only. Then you have the Thigh 3 category. The Thigh 3 says it is follicular origin. It is follicular origin. Now then you have another category, which is what we call it as the Thigh 4, which is dangerous. So Thigh 4 is what we call it as the suspicious of malignancy. This is going to be suspicious of malignancy. And the last one that you have is a Thigh 5 category, which is a malignant lesion. So it is a biopsy proven malignancy. It's a biopsy proven malignancy. Right? So these are the categorization that you have. So you have the Thigh 1, which is non-diagnostic, Thigh 1C, which is non-diagnostic but a cystic aspirate. So it's a cystic swelling. Thigh 2 is a non-neoplastic. Thigh 3 is follicular origin. Thigh 4 is suspicious of malignancy. Thigh 5 is a malignant lesion. So what are you going to do about these? If you have a non-diagnostic aspirate, you have to repeat FNAC under ultrasound guidance. Repeat FNAC under ultrasound guidance. If it is non-neoplastic, then you can ask the patient to do whatever they want to, so leave it. If it is follicular origin, because I cannot differentiate between the follicular adenoma and follicular carcinoma, I'll take the patient for lobectomy, that is to remove the lobe as a surgery and then do a frozen section. Now, frozen section is a section that is being done in OT, that is within the complex. You'll ask the pathologist to be ready with his microscope. You will send the section immediately. He will make the slides and then give you a report then and there itself. So this is called as frozen section. On the basis of frozen section, if it is benign, that is follicular adenoma, close and come back. If it is malignant, do your completion thyroidectomy. Now, if it is suspicious of malignancy, again you will do the same thing. That means I am going to do the same drill. I will do lobectomy with frozen section and then rely on this. If you're suspecting it, confirm it. The only way you can confirm it is by doing the biopsy, which is here. If it is malignant, then it is going to be stage-wise management. Then it is going to be the stage-wise management. It is going to be the stage-wise management. Okay? So this is how you are going to look in terms of categorization. Okay? So this summarizes your today's discussion about how we are going to approach the thyroid swellings. Clear? Chalo. So as we have come to the end of our second episode, we have completed the thyroid anatomy and physiology. Tomorrow's session would be dedicated for thyroid swellings. I would take a little bit longer session, because when you talk about particular disease or disorder, you have to spend a little bit more time. So these were crude raw concepts, so it is going to be crisp, right? Okay, why repeating FNAC under ultrasound guidance? See what happens, no? Why do you have a non-diagnostic aspirate? The reason why you can have a non-diagnostic aspirate is probably, let's say if this is the thyroid gland and the swelling is somewhere in between, right side, right in the center of the gland, there's swelling. You went with the needle, you're doing a blind procedure, thinking you're able to feel the swelling, you go in. What if you are too superficial, you're not gone into the lesion directly? Or what if you have overshot the needle and you have gone beyond the swelling, and that is why you're not able to get the diagnosis? To get that into perspective, with the ultrasound, we'll try to localize it and then we'll hit the target precisely. Okay? So with this, we end the session for today. Thank you so much for joining. Thank you so much for all the love and appreciation and the feedbacks. Again, whatever you want me to do, we will do in our Bailey series, but we'll make sure that we do cover to cover. We'll touch every single topic that is there in the Bailey, a little bit on my style. Okay? Chalo. So thank you very much. Love you all, guys. If you have anything, you can reach out. I've been telling you, if you have any questions, any queries, you can reach out on the Instagram. The page that you have, I have actually, is called The Surgery Guy. Any questions, any queries, post it down. It is by Dr. Sandeep Seeram Reddy. That is me. Okay? So if any questions, any queries, post it down here, and I'll be more than happy to help. Right? Thank you so much, guys. Thank you. Thank you. See you tomorrow. Tomorrow, trust me, it is going to be a pure clinical fest. I will show you how we actually deal with patients with the same. We'll keep Bailey in our notion. We'll not miss a single point, but at the same time, we'll also tell you how to apply clinically. With that, thank you so much. Signing off. Good night. Whoever wants the latest edition, टेलीग्राम पे मेरा ग्रुप है, वहां पे एक बार मैसेज करो, वहां पे ऑलरेडी अवेलेबल है, बताना नहीं किसी को. चलो, बाय गाइस, हैव फन, थैंक यू.